really glad to present in this case today. It's our first time presenting a case here in the round. My name is Daniel, or Daniel, if you want. I'm a trauma and a vascular surgeon here in Brazil. I did my trauma training back in São Paulo with Dr. Ribeiro. And then I did my training in vascular and the vascular surgery here in Londrina. You can go.
Good afternoon, everyone. My name is João Scorpione. I'm a surgery resident here at the State University of Londrina. Pretty honored to be here and to show our hospital to you guys. First of all, we have no disclosures on this presentation. Londrina is a city located in the south of Brazil, in the state of Paraná, and the population is about 600,000 people. We are located at the Londrina University Hospital, which is assembled right now as a COVID-19 reference institution. It counts with 11 intensive care units and almost 500 hospital beds.
So our hospital is a trauma reference. We have all specialties here available 24/7. We have 16 surgery residents per year and our own blood bank. So we start with our trauma case.
So the trauma case of the week is a 14-year-old male with an abdominal stab wound. Time from the event is an hour. The initial assessment of the patient was he had no upper airway obstructions, he had no chest traumas, a normal respiratory rate. The patient had abdominal pain with no external bleeding. He was stable, non-dynamically, and the FAST was positive. The Glasgow Coma score of 15, and the patient exposure, he had a gastric stab wound with epiplon evisceration.
So at the time we got this injury, just the patient was eviscerated with the epiplon. He was stable and the FAST was positive. So we think what to do next. Two questions remains: how to resuscitate this patient as he was stable and the FAST was positive. If we resuscitate with crystalloids, blood products, or no fluid infusion. And our second question is how to proceed now with a CT scan, laparoscopy, or go for an open approach.
Dr. Alex, your comment, sir?
Yeah, so to go for the first question here, I mean, I suppose you can, start with some crystalloid, but I wouldn't, give too much crystalloid. He's hemodynamically stable now, but that's really evisceration with a stab wound in the epigastric right there in the middle. Kind of makes me think about how deep did it go, and maybe it went to the aorta or vena cava. So I would be prepared for a balanced resuscitation with blood product. And I would not go to the CT scanner, even though he's hemodynamically stable. I think laparotomy would be my first choice here. Thank you.
Thank you, Dr. Alex. Dr. Christine.
Good morning. So the dictum in surgery calls for resuscitation only if it is very urgent. In a case like this, when the patient is fairly stable, you have the luxury of keeping the intravenous line open rather than giving him maximum amount of fluid. In any case, I strongly recommend that we don't do that anymore. We should not give more than a couple of hundred cc of IV fluid just to keep the line open, and then resort to blood product, if it becomes necessary. So in resuscitation in this particular patient, I would just put an IV line in and give a minimal amount of crystalloid fluid just to keep the line open, and then get the cross match established, because you will need it, because you're looking at zone 1. The next question is, if you can get an idea what type of knife was used or what was the offending instrument, the assailant, did to the victim, you will have a rough idea at least how maybe how deep the stab wound may have penetrated. And second, he's a young fellow. He will compensate very quickly, and then he will crash later on. You know, when the appropriate time comes for him. So other than giving him minimum amount of fluid and getting him stabilized, getting him ready, I would not even go for the CT scan because it is not indicated. You're not going to get any further information from a CT scan to help you in the eventual treatment of this patient. And he requires an operation because this particular scenario, as you see, evisceration calls for an operation rather than any further investigation or non-operative therapy. Thank you.
Thank you, Dr. Kassim. Dr. Calais, your comments, please.
Yes. In this situation, I have a stable patient. We start with a crystalloid to reposition or to make assess for the fluids in this case, and try to make an example of blood examples to make a cross match of blood because these patients may need some transfusion later. But if as a patient is stable, you have signs of clear that you can go to laparotomy or you can open or see what's happening in the abdominal cavity. So in this situation, this patient is stable. You can see the people, of course, in any small services, you can go to a laparotomy and try to fix it, make an exploratory and fix the injuries in the abdominal cavity. But sometimes in situations in the hospitals, clinics, you can take these patients to a CT scan and see there is signs of evidence of injuries of blood, of vessels in the midline, or vessels or tamponate in this situation. If you have some signs of tamponate vessels injuries in this case, you can go to open the patient. Or if you don't have, you can go to a laparoscopy. You can put the people into the abdominal cavity, close the skin, make a punction, insufflation the cavity, and make an exploration by laparoscopy in this situation. In this situation, it can be possible. But of course, you not know the only CT. You can do the CT and go to laparotomy or go to laparoscopy. But in these situations, if you want to make a laparoscopy, you need to go to a CT scan, an angio CT scan for the abdominal, to avoid great vessels injury tamponate. That's the way.
Thank you, Dr. Calais. Let's go to Baghdad. Dr. Untrack, your comments, please.
Yes, I pretty much agree with all the comments. So that resuscitation, so now the rule is damage control resuscitation to a systolic pressure of 90. So this patient already, he doesn't qualify for resuscitation because his own status is beyond the target. So, I agree with what everyone else said. I think the limit now for a full-size adult is a liter or 1,500 cc's of crystalloid total throughout the whole, the whole preoperative and intraoperative portions of the treatment. So I would not. I would just put the IVs and keep them open, be ready for if he goes into shock. And about the others, I agree. I mean, this is when you have evisceration, you have the omentum outside, and you have a positive fast. In most places here in Baghdad, we'd go to the operating room and explore. However, with a stable patient, I can see, wanting to go to CT to be sure that there's no aortic injury or major vessel injury. If there's an aortic injury, and then you have the means to put in a stent, I can see that maybe you would do that in this case, put a stent in and then go for laparoscopy to rule out other more superficial perforations, and then you can avoid making a 6-inch incision and just fixing it directly. But otherwise, I would do the laparotomy. The other thing is this patient is, you say, 12 years old. So he's not full grown yet. I don't even know if that's an option to put a stent in someone who's not fully grown yet. If he's still, a teenager. So that might make that argument moot in this case. But I think that, in most cases, a patient like this, you should go straight to the operating room.
Thank you, Dr. Untrack. Been informed that Dr. Ruiz is present. Dr. Ruiz, would you like to comment?
Yes, yes, thank you. So I agree with the previous comments. There's no indication for imaging on this patient. Evisceration of abdominal contents or omentum is an indication for exploratory laparotomy. I don't think there's a need for resuscitation either at this point. We don't use crystalloid in our trauma center for resuscitation anymore, but that's because we have the luxury of a blood bank. Now, can you find something surprising in the operating room? All the time, but we should be ready for it. So the patient will go to the operating room with uncrossed blood, and we will send the type uncross and be ready to get MTP if the need arises. But I would not take this patient to imaging and would not resuscitate the patient with any special crystalloid or even blood at this point.
Thank you, Dr. Ruiz. Any more comments before we return to our presentation? Okay, gentlemen in Londrina, back to you, please.
So as the ABC score of 2, we started a transfusion protocol and sent the patient to the operating room for an open approach. In the abdominal cavity, we found a moderate amount of blood and a zone 1 hematoma with active bleeding and a transverse colon perforation that was primarily sutured. And the patient remained stable at that time.
So our third question is how to proceed now. What we see in the surgery was zone 1 hematoma with active bleeding, important active bleeding. So how to control the bleeding in this case? If go with a Reboa or maybe a Matox maneuver or a supraciliac aorta cross clamping, how to proceed to first stop the bleeding? It's our third question in this case.
Let's start with Dr. Untrack on that.
Yeah, so it depends upon the, you say heart rate of 80, blood pressure 100/60. So active bleeding, it sounds like not torrential bleeding. So in this case, and not being there, but assuming he's got active bleeding that you need to stop, but it's not enough to cause him to go into shock, I would opt, especially a thin patient, looks like from the picture is nice and thin, I would get control at the esophageal hiatus, at the diaphragm, and have control there and be ready to apply a clamp, and then get the exposure either with a Maddox maneuver or through the, I guess you'd have to do a Maddox maneuver, but once you deal definitively with the vascular injury, you need to carefully explore the entire lesser sac, including the pancreas, to rule out an injury there or deal with it appropriately, either resection or Roux-en-Y limb or simple drainage, or not, or you may not need anything there, but you need to carefully explore the entire lesser sac.
Thank you, Dr. Untrack. Dr. Collette?
In this situation, we have blood come from the zone 1. Can be arterial or can be venous blood, because there is sometimes maybe different. In this situation, you can have injuries. You can see here of the cava vein, renal vein, aorta branches, and you can see also have mesenterical, superior mesenterical vein and artery injuries. So in these situations, you can have injuries in this case. If you have opened the abdomen, you can maybe a Maddox is a classical description for control of the aorta in this situation. If you can go make discolation of the left colon and the left kidney and find the aorta hiatus and put a cross clamp in the aorta. You can do the same if you go to near the hiatus, esophageal hiatus, behind the esophagus, you can find the aorta. and you can compress the aorta with your finger, or can put a clamp in the situation. You have go to directly to put a clamp in the aorta hiatus, beneath the esophagus, in the gastric small sac. It's not in this occasion. This patient is small, is thin. It's maybe easy to clamp in the aorta in this size, and then you can go to exploration of the hematoma.
Thank you, Dr. Khaled. Let's go to Portland. Dr. Kasim?
The way I approach this case is what will give me the best a sense of confidence in preventing any major blood loss in a very young patient like this, who probably does not have a large volume of blood in his circulation. I don't want to lose any blood whatsoever. So the first thing I would do would be expose the aorta near the hiatus and get a vessel loop around it. I think the surgeon is a vascular surgeon, and we all know how to do that. And I've done that 100 times. And then I can get a control of the supraceliac aorta, and then I can go ahead and do a Maddox maneuver. Maddox maneuvers is the best maneuver in this case, because you get to see the celiac axis, you get to see the supramesenteric vessel, you get to see almost a panoramic view of the area, and you'll be able to get control of any bleeding in this area with impunity, without getting any nervousness, because you have the luxury of cross-clamping the aorta at the hiatus. And that's what I would do. I would not think of any shunts or anything like that in a young patient like this, because I don't think that is indicated. Thank you.
Thank you, Dr. Kasim. Let's go to Ryder, Dr. Ruiz.
Thank you, Gary. I agree with Dr. Kasim and the previous audience, but there's one thing that I always tell my fellows when we encounter a situation like this, and unless there's a massive exsanguination, the first thing that I tell my fellows is stop. Do not be wild to go after this right away. You have to be sure that everything is ready for you. Okay, so the first thing, and I think somebody actually proposed this in the chat, is to put direct pressure in the area. And you for sure can stop the bleeding with direct pressure in the area while you get the anesthesia team on board. They should have a central line in place or a big access in place. They should have the blood available. You should have all the instrumentation that you need. I agree with the surgeons that are suggesting to dissect at the crura, so you're going to be able to control the aorta at that level. Putting a clamp in this area just above the renals. I don't know how many of you guys have done it. It's almost impossible. The clamp just doesn't purchase enough. The clamp comes off. You have to dissect above close to the crura. But my first, the first thing that I say to my fellows is just put pressure on it. Stop. Take a deep breath. You are not the one who's bleeding. Don't go crazy. Be sure that you have everything ready before you dive in.
Thank you, Dr. Ruiz. And Dr. Alex, you still with us, sir? Dr. Alex, maybe stepped away. Okay.
I'm back. Sorry.
Okay.
Sorry.
Take your time, sir.
I'm also off on trauma today. So I agree with the comments. I would not put a reboa in this case. I think it should be easier to just do supraceliac control of the aorta. So there's active bleeding. So if it's arterial, obviously, then I would go and perform a Maddox maneuver. If it's venous, I would probably go and do a Cattell brush and look for an injury to a venous vessel like cava or portal. That's how I would approach it. And I agree with, making sure that, you have the blood available and MTP for expecting a large amount of bleeding. Thank you.
Thank you, Dr. Alex. Any further comments before we return to Londrina? Okay, back to you guys.
Okay. So in this case, the first thing that we did was a digital compression and take a big breath. Then we perform an aorta cross clamping, just in the supraciliac cross clamping, with no control of the bleeding. And at this time, we perform first a Cattell maneuver, a Maitox maneuver, then a Cattell maneuver, and finally we find a major bleeding from superior mesenteric vein.
So we found a superior mesenteric vein injury that was higher than 70%. We can see that in the picture, right at the arrow, the lesion went through the vessel, so it was difficult to suture it. And then after the bleeding control, we found a significant cyanosis of the bowel and a major bowel distension.
Well, now at this point, we found this injury. The patient started to be hypotensive, a little tachycardic, but with no acidosis. With this injury, after we control the bleeding, the small bowel starts to get with important distension and cyanotic. So what to do now? Maybe repair this injury, just ligate it, or shunt this injury?
Portland, Dr. Kasim, your comments, please.
I would strongly recommend you ligate it. There is a paper that I have read just recently. Any type of repair in this area causes higher mortality, and the author did not explain why that is so. But maybe Dr. Ruiz, who is a very smart fellow, he'll be able to tell us more about it when it comes to his turn. So my recommendation would be, from the literature that I have read, I would ligate it. Of course, being a vascular surgeon, I am very tempted to repair this. You know, I would like to repair it because I know how to repair things. And but this particular paper tells me that it is better to ligate it than to shunt it, repair it, etc. Sometimes, you know, you can do the anterior repair, and there will be a hole in the back of the superior mesenteric vein, and it'll start bleeding once you release the clamp, and then you will be losing more blood. Anyhow, the literature teaches me to ligate it, but my personal ego tells me to repair it. And but I would love to hear what Dr. Ruiz will teach me. Thank you.
Okay, how about that, Dr. Ruiz?
Wow, that's a tough one. I cannot really teach Dr. Kasim anything, to be honest with you. You've been around for much longer than I am. But I was afraid that the presenter was going to throw us something like this because it's a tough one. It's a tough situation. Dr. Kasim is referring to Dr. Asensio's studies that showed he had a retrospective review. I think it was 150 some patients that had this injury, high mortality, high morbidity. Ligation should be favored on those patients that have hemodynamic instability. Now, having said that, we've seen successful repairs on simple injuries on patients that are not hemodynamically unstable and have not many associated injuries. But the repairs are, as Dr. Kasim said, fraught with complications, portal vein thrombosis, bowel ischemia. These patients, if you decide to go for the route of repairing the injury, I will leave the abdomen open to be sure that you can go back and be sure that the repair is patent and there's no bowel ischemia. But it's a tough case. If the patient is hemodynamically unstable, if the patient is bleeding, you should ligate the injury. Those could be survivable, but allowing the patient to bleed and become coagulopathic just because you're trying to repair this thing is probably the path into a bad outcome.
Thank you, Dr. Ruiz. Dr. Clay?
Yes, I think this patient is unstable, very, very unstable. I try to ligate it. but ligate is not a good treatment for this injury in this position. When you ligate this injury in the young patient, you have no collateral venous in development in this patient, and have a very edema of the ball, and problems you have become from this. You can try to repair. If the patient is unstable, I try to put a shunt, because for repair these injuries, we need to make pieces of vein, of femoral, saphena veins, or make a jugular veins to put a shunt or a stent, a shunt in this patient. So can maybe we have to put what's this? Enxerto is you can put interpose a piece of vein in these situations to repair these injuries. These injuries is very difficult to repair, and if the ball comes very edematous and maybe heavy, and in this position they push the artery at the vein and then collapse the vein. So to repair this vein, you need to make the diameter of this vein very big, not very small. So I believe these patients need to repair this vein, and sometimes if you have to put a shunt in these situations to make to a measurement control to try to select how to repair this vein.
Thank you, Dr. Khaled. Baghdad, Dr. Untrak.
Yeah, so based on where the injury is, it looks like it's the confluence of the superior mesenteric and splenic veins. So to ligate the injury, it's ligating all three, the portal vein, splenic, and superior mesenteric veins, and in a setting where there are no collaterals yet because it's acute. And then I guess he could have if he gets varices, he could drain ultimately through the coronary vein. But if right now he's tachycardic and hypotensive, so if it's for damage control, then in this case, and not being there, but if you think he's not going to do well to continue the operation, then you either need to ligate or place a shunt from the superior mesenteric vein to the portal vein. The flow is usually big enough, and that might be enough for damage control. Ligate the splenic vein, and then come back after he's recovered, or just simply ligate and come back and do a mesocaval shunt, or whatever might be necessary to relieve the cyanosis if that becomes necessary. But it's in this case, because of his vital signs, I think it's a tough decision. It's not so clear cut to proceed with a repair.
Thank you, Dr. Untrak. Dr. Alex, your comments, sir.
Yes, so I see, pancreatic tissue right there, and that's something that if you have, pancreatic enzymes leaking on a repair, it's just gonna be a matter of time until that's destroyed. Looking at the patient's blood gas, blood pressure, and heart rate, and looking at the picture, I think I would be in favor of trying to repair this primarily. I would, of course, I would just reach out to a vascular team while I, get things going and started. If the patient is really unstable, then I would elect a shunt, especially if there is a lot of pancreatic tissue destruction there, to be able to come back with a more definitive repair and a plan to address the pancreas, whatever it's injured. I don't know, I may need a resection or some other form of reconstruction, but I would be in favor to repair this, even if in order to get to the repair would be to shunt and regroup and come in 24 hours.
Thank you, Dr. Alex. Dr. Ginsberg made a comment in the chat. Didn't know if he wanted to comment to the group, or you want to continue to observe, Dr. Ginsberg?
Basically a superior mesenteric vein injury, you should always attempt to repair. If you ligate, you end up with basically dead gut. although it's very tempting to just ligate in a dying patient, it's pretty much recommended to repair. Was this a gunshot wound or was this a motor vehicle accident?
A stab wound.
Oh, a stab
Stab
wound.
wound.
Stab
Yes.
wound.
So in this type of case, I think it is vein. You see the two lips on each side of the stab wound, and so I think you should try to repair. If you want to put a stent, you can go ahead. But repair, I think, is the most important thing. I had a motor vehicle accident about, I think it's been 2 months ago. Believe it or not, had a injury to the superior mesenteric vein and abrasion, basically some injury to the pancreas also. And we repaired it. First, I put clips. Then I repaired it real quick and then pulled off the big clips, because putting, big old peripheral vascular clamps is like putting a big old clip on it, and then he's had complications, but not from venous obstruction.
Thank you, Dr. Ginsberg. To everyone who was interested in Dr. Asensio's paper on SMV injuries, Dr. Ruiz was kind enough to share a link in the chat section, and you can find it in there. If no further comments, we'll return to the presentation.
Okay. So at this point, as a trauma surgeon, I really want to ligate this injury, but as a vascular surgeon too, our option in this case.
So we performed a great saphenous vein patch with a Prolene continuous suture, and because the patient tended to be hypotensive at that time, we proceeded with damage control procedure with a Barker's technique.
So at this point, we perform the great saphenous vein patch. In the table was our time in the surgery. Then we perform damage control surgery.
So we performed a second look surgery 24 hours later. We saw that the patents of the patch, the small bowel was found viable. There was no new sources of bleeding, and the patient was extubated on the second post-operative day. He was fed on the 5th, but the patient presented with fever on the 7th day, post-operative day, and we performed a CT scan to investigate an infectious site.
So our major hypothesis here was maybe an abscess, but here on the CT scan, please pay attention to the aorta. So there is some of a free fluid. There is an injury in the aorta too, and some of a free fluid in the pelvis. So here we have a pseudoaneurysm just below the right renal artery, and two hypotheses came up. It was related to negative pressure or a missing injury. Unfortunately, we know this was a missing injury. We didn't see it on the first approach. After the control of the mesenteric vein injury, there was no bleeding anymore. And in the second look surgery wasn't bleeding too. So we found this injury here on the reconstruction of tomography. There's an injury just below the right renal artery. Then we measured this injury for planning for maybe endovascular treatment or an open approach. So we have the size of the aorta and the right renal artery. The injury was in a 14 years old patient. And to additional details, we perform an angiography So we have this injury right below the kidney artery. So in this case, now if you go for an open repair, like it's a missing injury, or try an endovascular repair with vascular team, it's our last question in this case, how to proceed.
Dr. Alex in Philadelphia, your comments, sir.
Well, that's a little bit of a tough one. So first of all, he's young, so even if you have a landing zone for a stent, you know, he's with being 14, you know, whatever size may be when he's 14, in 10, 20 years, you know, maybe that graft may be a problem with it. I would certainly request a vascular input on this, but probably it would have to be explored and go and see how you can repair that. I was looking to see if there are any accessory renal arteries coming off of the aorta, but I don't see any on this angiogram. That way you may be able to, you know, just kind of fix that because it's right at the confluence, and then, you know, if you have to ligate that, you still have flow to the right kidney, but I don't see that. So I'm curious to see how you proceed, but probably I would go with open with vascular. Thank you.
Thank you, sir. Dr. Ginsburg, Ryder, your comments, please.
Well, I'm glad I don't do endovascular work because it looks like a very tough place to put a stent where most likely you'll knock off at least one of the kidneys. I think so. I would ask my endovascular people if they would be comfortable doing this. They'll know more about it. If not, I think a retroperitoneal approach from the right side, since this is on the right side, right below would be the approach, so you stay out of the belly, and I think you could get control with a couple sutures of the aorta and save the renals. It looks like there's space between those renals, but I'd like to see what the endovascular people said.
Thank you very much, sir. Let's go to Dr. Kasim in Portland.
So there are two options available for you: an endovascular approach as opposed to open. Naturally, I would prefer endovascular approach, and I believe that I have seen a case like this here in the iliac following a stab wound. And what they did was they put a wire in and they put a whole bunch of coil and thrombosed the pseudoaneurysm, and they got away with it. So that is something that I would probably explore to see if such a maneuver is feasible in the abdominal aorta just below the renal artery. If it is not available, and then my choice is very limited, and I would, I don't know how much exposure that you created in your first surgery, whether you went anywhere near the infrarenal abdominal aorta. If it is still virgin, then it is like doing an aneurysm. Just open up the abdominal aorta and go ahead and clip the pseudoaneurysm or ligate it, and call it a day. That's what I would do. But I would prefer the endovascular approach, putting a wire in there and putting coils, lots of coils that thrombose the pseudoaneurysm. Thank you.
Thank you, sir. Dr. Untracked, your input?
Yeah, so you know, the endovascular surgery is after my time. There's really technical issues being so close to the renal arteries, and then the size of the aorta, the age of the patient. So I think I would leave it to the endovascular guys. If it's something they do every day and they feel comfortable, fine. Otherwise, it should be an open operation. I think to deal with this, though, it's actually a primary repair or just ligation. I thought it was you'd have to actually get control proximally distally, put a few sutures, full thickness. But am I wrong about that, Dr. Kasem? That you can just put a clip or ligate the neck?
Well, you can put a clip, and they do this in the head all the time.
For a true aneurysm, but anyway.
Right.
So regardless, I'd leave it to the vascular guys. But and then the other point is, are you sure this is why he has the fever? That would be the last question. Is that the cause for the fever? Is there nothing else going on? But is this just incidental?
Is that a question for Dr. Mauro?
Well, I would just end my comments there. I mean, that I would be concerned whether that's the cause of the fever as well.
I see. Okay. So Dr. Calais, Sao Paulo.
Yes, I agree with all comments. Today is very easy to put something in endovascular treatment. Can put a stent in the renal, put a stent in the aorta. A combined use of stents through endovascular procedure. The great problem is in this situation, this young people, the teenagers go to maybe not, she's going to increase his age, he's going to increase his length, and sometimes the aorta go to increase. So during the next age, and what's a patient will happen with the stent in the aorta? The stent is limited the size of the aorta, and the children will go to grow. And so it's very important to think about when to put a stent in a child or in a teenager, because the patients go to the development and go them. So in these situations, I think it's very important to think about this. And go to have to repair. To repair is a pseudoaneurysm through the acute injuries. It's not very difficult. Today it's difficult to repair opens in the situations because the aorta is inflamed because the procedures and because the pseudoaneurysm is acute. It's not a chronic pseudoaneurysm. So to only ligate the neck of the pseudoaneurysm is not possible. The tissues is not good, it's inflamed tissues, and sometimes you have problems when do that. So in situations, maybe you have to put a graft in this position too. So a partial graft maybe. So I think it's very important to do what to do, because a child and endovascular procedures in the adults is okay, but in child and teenagers, I don't know. And sometimes it's a problem. And I agree with the fever. The pseudoaneurysms don't get fever in this patient. What's the problem with the patients? The fever is an infection disease. Maybe this pseudoaneurysm may be an infected pseudoaneurysm or not.
Thank you for your comments, Dr. Calais. Dr. Ruiz, your input, sir.
The presenters, congratulations. You keep us on sending us unexpected curveballs on here, on this case. That's a tough situation. I agree with Dr. Ginsburg and most of the other participants. You need a good vascular surgeon for this. Nowadays, I've seen them pulling this off on an endovascular fashion, with the caveat that this is a teenager. And I don't think there's really studies going on 40, 50 years of a stent. If the decision is made to do this open, definitely not transabdominal. I agree with Dr. Ginsburg. This should be done on a retroperitoneal fashion. This goes beyond my skill, obviously, so you need to enlist a good vascular surgeon to help you out.
Mm-hmm. Thank you, Dr. Ruiz. Any further comments before we return to our presenters?
Yeah, it's Dr. Ginsburg.
Yes,
I just wanted to make, I had, are you there?
Please.
Hello?
Yes, sir. Go ahead, please.
Looking at this, I forgot about the fever. And if this is an infected pseudoaneurysm, then basically you got to, it's not just a matter of throwing a couple sutures for, you know, small stab wound. Need to debride, you know, I think ligation of the aorta at this point in this young kid would be a horrible thing to have to do, and then end up with an extra anatomical bypass would be just basically, you know, just horrible for this kid's future. So I think, you know, obviously if you can get a stent and put him on antibiotics and hope that this is not the source of the infection is an approach, but it will make difficult if it is and he continues to have infection, and then have to transect the aorta and oversew and basically put in some sort of you know, tissue. We have this new graft which is made out of, I can't remember if it's pig or what it is, but it's supposed to be resistant to infection. But in this case, if you do have to come across it, you can come across it at a very significant angle and possibly sacrifice that right side. And debride everything very well and put in a Gore-Tex graft, you know, as a interposition graft, and then just lots of antibiotics. I just can't imagine ligating and losing his kidneys, or having to do an extra anatomic bypass on this kid at the age of 14. Interesting, complex.
Thank you, Dr. Ginsberg. If we have no more comments, we'll return to our presentation. Okay, let's continue, please.
So just answering about the fever problem, we performed a thoracic CT scan. Patient had a pneumonia, so it evolved pretty well with only antibiotics. So we agree with all of you. Although aortic grafts were made for aneurysm disease, in this case there was an important proximity with the right renal artery. So we would need to do a chimney technique that has poor outcomes, poor long-term outcomes, and especially in young patients because of his growth. So we performed an open approach, again with laparotomy. We did a suprarenal cross-clamping and did a Prolene suture with success, and the patient was discharged 15 days after the trauma.
So this case was really hard. Every step of this case was hard. The control of bleeding in the first surgery, it was hard to see on the CT scan, the pseudoaneurysm. And we thought a lot about an open approach or the vascular approach. And the vascular approach maybe can have poor outcomes for the proximity of the right renal artery. So we decided to go for another laparotomy. Wasn't easy, so we performed a suprarenal cross clamp and just suture with a Prolene. It was really hard to do, but we achieved the success. Finally, the patient was discharged after 15 days of the trauma. This is the CT scan after 30 days of second approach. There isn't injury of the aorta. The small bowel was viable. There is not free fluid in the abdominal cavity. So the patient is still doing well today. Was really a challenger for our team. So we finished this presentation. We'd like to say that we appreciate the opportunity for participate, and thank you very much for your attention.
Thank you, sir. Let's go ahead and get our final comments from Dr. Ruiz.
Thank you. Excellent case. Definitely makes you think about things, and it's kind of shows what happens in trauma, right? We always get in the unexpected. Now, I would love to hear from a vascular surgeon what data is on the long-term, placement of these stents. How long have they been followed up? I remember when I was training, we didn't even have 15 years of stent studies. So I don't know if that has improved. I mean, I haven't finished. I did finish my training some years ago, but I don't know what the studies are on the patency and complications, etc., because it's concerning. In such a small child. Excellent presentation, incredible case. Congratulations to the team.
Thank you.
Thank you.
Thank you, Dr. Ruiz. Let's go to Dr. Kasim. Your final comment, sir.
Not only a very interesting case, but your illustrations were just beautiful. All the pictures you showed us, just remarkable pictures you took. And moreover, you thought out very, very carefully about the pros and cons of doing every procedure that could be applicable to this particular case. And you came up with the best in your opinion, and you salvaged this very young person from lots of problems. Really a very educational case, and I shall remember this till the day I die. Thank you.
Thank you.
We all hope will be a very long time, Dr. Kasim. So, Dr. Calais, your final comment, sir.
Oh, I have to congratulations on the case. Very illustrative case. It's very difficult to decisions to have. Thank you for presentation. Share this case with us. Thank you.
Thank you. Let's get Dr. Alex. Your final comments, please.
A great job with managing this case, and thanks for presenting it. I'm actually glad that he underwent an open procedure, just because endovascularly we can do a lot of things today and put wires and coils and everything. This may not, or stents, this may not have been the right option for this patient. I saw on your diagram that this aneurysm was really close to the right renal artery. So you probably thought about, in the event that you get where you have to really get close with your stitches to the right renal artery and you're occluding it, if you consider options for repair or bringing inflow to the right kidney, like maybe using the right GDA or just to reimplant it in the aorta in a different spot, if you can comment on that. Thank you.
Thank you, Dr. Alex. And Baghdad, Dr. Untrack, your final comments, please.
Yeah, so a great case, a lot of very good teaching points, and I also have a couple of questions about to follow up on what Dr. Alex said. So I take it you approach it like for an aneurysm, transperitoneally and open the peritoneum. So and the aneurysm, I take it, was anteriorly to the vena cava, and then the repair. Did you do a primary repair? You resected the annular primary repair, did it that way, or I assume that's what you did. And then also, I think it's remarkable that with the way that the knife went, the pancreas uninjured, no drains, everything, no pseudocyst afterwards. So that was kind of interesting that with the injuries he had, that the pancreas came away unscathed. But excellent case.
Thank you, Dr. Untracked. Dr. Ginsburg, your final comments, sir.
Very interesting case. I mean, beautiful management, and congratulations.
Thank you, Dr. Ginsburg. So thank you all for joining us. Thank you for presenting. Go ahead, Dr. Untracked.
Yeah, I guess so. I guess there were some questions outstanding for Drs. Mauro and Scorpione about the aorta that Dr. Alex posed, and if they wanted to answer.
Oh, okay. Yes, please go ahead.
Dr. Alex, you asked about the renal artery patency. Is that it?
My question was, in order to address the aorta, if you had to come across the right renal artery, what options to bring inflow to the right kidney you considered preoperatively? Use the GDA, or you thought maybe to reimplant? Well, what would be, if that goes bad, obviously, you were able to close it primarily, but what were your thoughts before going into surgery? How are you gonna bring inflow to the right renal artery, to the right kidney, in the events that you may have to ligate that?
So in that case, we thought this injury just passed through directly to the aorta, and to prevent maybe a kidney ischemia, we can just, what we thought on that day was to just do it quickly, and try to avoid the right renal artery. And maybe if we need to access or just ligate the kidney artery, I think one option is to do an implant in another spot of the aorta, but gladly we didn't need to do. Just the suture was solve the problem.
Okay, so if I can follow up with the question I asked, so basically, I take it you resected the aneurysm and did a primary repair of native aorta to native aorta with sutures.
Yeah, we think that maybe we can use a graft just to do another patch in the aorta, but just was 3 surgeries in this patient, so the risk of infection, I think it was really big. So the primary repair, I think, was the best idea in this case.
And Dr. Goes, I see your team there. Yeah, check your mute button, please.
Doutor Manuel, o senhor está mudo o seu áudio. I just talk in Portuguese too.
Okay, good.
Okay. I want to congratulate Professor Daniel and Dr. João. Daniel has done a good job here in Londrina. I'm a professor also here. This is our students of medicine and resident at first year. And I just want to congratulate for his job and the good comments that we are learning here. Thank you.
Thank you, Dr. Goes. In the future, if you wish to join and participate, just let us know. You're always welcome, okay?
Yes, Gary, let me also say thank you very much to Dr. Mauro and Dr. Scorpione for sharing your case. This is your first presentation, but we certainly hope this is not the last one. You're always welcome to present. And if anyone else has a case, please to contact me by email.
Yes, last thing to Doctors Mauro and Scorpione, just from non-medical person who's observed a lot of conferences, yours was very well put together, well presented. It was polished. It was very nice. Thank you.
Thank you very much. Thank you very much. We're really happy to participate.
All right. We look forward to seeing you again.
Okay.
So watch your email. Valeria will be sending out information to everyone. But in the meantime, please, everyone, take good care of yourselves. And I look forward to seeing you the next time, okay?
Goodbye. Thank you all.
Bye. Thank you.
Thank you. Bye.